All right, everyone. I'm going to be doing pharmaceutical advances, what's new in patient care. I kind of added the rapid fire style because there's no polling questions tonight. It's an hour talk or 50-minute talk. We'll be wrapping up at about 8:25 Eastern. This is a synchronous virtual course. I do have the webinar chat open here, but lots of things are flowing in there, Joe. So any questions roll in, please keep an eye on that for me.
Will do.
I'll be doing the presenting, hosting, moderating. Joe will probably throw some comments in, and Vanessa is our webinar administrator. So let's get started. Here are my disclosures. Anywhere from Alcon to Dompe down to the Optometric Visionary team. I've received honorariums for those advisory boards and have lectured for these different companies. I am a non-salaried affiliation with Pharmanex. Will not be speaking on any of those products tonight. I do sit as a chairman advisory council for diabetes and macular degeneration for the healthcare registry. That's an outcome-based registry. But here's the most important. Independently prepared by me. No one's telling me what to say. I'm going to be mentioning products tonight and pharmaceuticals. I'm not claiming any superiority, and everything has been mitigated with the proper channels. All right, here's my practice in Duncansville, Pennsylvania, a single standing building. We have about 5 optometrists that work there, and you can see we have an optical, we have lots of fun equipment. What I always like to point out is I like to take the science is great, but if we really can't apply it in clinic, then, like I was at OGS and they were talking about growing axons and crushing them. Like that's cool for the future, but how can we apply it in clinic? And that's what I try to make, and Joe tries to make most of our lectures, so that tomorrow you can be hopefully a little bit better in clinic and in patient care. All right. So trends that are happening in pharmacology. And Joe, I'll see if you have anything that you want to add to this when I'm done going through this.
Mhm.
The drop size keeps getting smaller, right? We see that, Mibo has a 10 microliter drop size now. Preservatives are now being recognized as being toxic to the ocular surface. When I was at the OGS the last few years, the Optometric Glaucoma Society, right? We always focused on that nerve and the ganglion cell and the axons. Now they're starting to talk about how that BAK most notably is creating an ocular surface toxicity. And one of the things I like to point out is it when we go through here today, is it a new mechanism of action or is it a new mechanism of delivery that's out there? So that will help you out. And I have a slide coming up on that. Joe, have you seen any trends or anything you'd like to add to that?
Well, one of the trends that I've seen a lot of is not only the drop size getting smaller, but everything is getting less frequent. The goal has always been, once a day. We used to have 4 times a day drug. We know that doesn't work. 3 time a day drug, very tough. 2 time, maybe. 1 time is what they always want to do.
Perfect. And in the chat, I'm not sure if this is dangerous or not, but I changed it to where everyone can chat to everyone. So we'll have to police that, Joe, and see what
Mhm.
happens. All right, here's the problem in a sense, or why maybe you're seeing it. If you look at the physiological tear film, if you look at the reflex, the functional tear reserve, the eye can really only hold, 10 microliters. So that's why most drops are 5 to 75, 25 to 70 microliters in size. So that doesn't matter how good you are putting that tropicamide in or that proparacaine in, you always get some that runs down because those drops are 30 to 40 to 50 microliters and it can only hold 10. So that's why there's always a little bit running down the face, no matter how good you are putting those drops in. So the drops, in a sense, are larger than what the capacity of the eye can hold. So maybe that's why we're starting to see kind of this 10 and 11 microliter type of movement. Again, glaucoma, if you have a glaucoma practice, I'm going to tell you now, when I raise when we do this live, how many of you treat glaucoma? And 50% of the office, or audience raises their hand. I say, well, not only are you good at treating glaucoma, you also now have an ocular surface disease because if you start getting around, 1, 2 topical medications, chronically exposing that eye to most likely BAK, it's going to cause the ocular surface to get beat up over time, and maybe even some conjunctival changes that occur. And there definitely is a relationship between ocular surface disease and a number of preserved medicines. I don't think this is, this is great to have studies. This came out in 2012, and you can see here single drop therapy creates ocular surface disease, mild, moderate, and severe. And you can see as you add more drops, the severe and moderate start to take over with that ocular surface disease kind of relationship. So, the preservatives in IOP medications certainly dominated by BAK, which is a wonderful antimicrobial preservative. But with that comes the side effect of how it beats up the ocular surface. And we do have some alternatives over here, Purite and potassium sorbate, but there's just a handful of preservative-free medications that are out there. I've been using the preservative-free latanoprost on a few patients, and it's amazing the comfort, the ocular surface healing that happens. It's just whether or not we can get the patients to pay that $60 copay for that. We try it on it and we let them decide. I don't try and make the decision for them. I've had a handful that say, "Look, my eyes feel better. This is worth me paying for this, this medication." So keep that in mind when you're out there prescribing. So, mechanism of action, mechanism of delivery. When a drug rep comes in, or if I walk through an exhibit hall, or I'm talking to, something that's new, what I try to boil it down to, is it a mechanism of action or is it a mechanism of delivery change? Mechanism of action, we really haven't had anything in the glaucoma realm. My first lecture that I did as a residency in 1995, 1996 was latanoprost. And if we think about glaucoma medications, when was the next new mechanism of action? It really wasn't until Ropressa, right? We had the Trusops and the Azops, but they were already used systemically elsewhere. So mechanism of action, the new ones that have recently come out is Notarsadil or Ropressa. Mibo is a new mechanism of action. And Xdenvi, inhibiting that GABA chloride channel, those are all new mechanism of action medications that recently came out. Now, mechanism of delivery, that's kind of what we're seeing with the cyclosporin products, right? So Restasis, 0.05%. Uh, I think my mom might have fell, so hold on. Give me a pause. All right, so 0.05%. My brother's downstairs, so I'm not ignoring her. 0.05% has now doubled in like Vive to 1%. But the mechanism of action didn't change by doubling it. But what they did is they gave a new mechanism of delivery. So loteprednol came out, and Lotemax is a good example. Lotemax came out and it's still loteprednol, but Lotemax SM, what they did, as you can see here, is they made it smaller. And that becomes more of a mechanism of delivery change that's occurring. So the other thing that I like to point out is when it comes to pharmacology, is that we like to have you have to understand receptors, right? We have to understand that how these medications are interacting with the receptors. And this is from my opioids talk, is that we have mu, kappa, and delta, and that's what the opioid plugs into. And you can get different reactions. When it plugs into the mu, you get analgesic and euphoria, but whenever it plugs into the kappa, you can get a dysphoria, but you get the analgesic. So you gotta kind of have to understand how these medications do plug in to the receptors. So these receptors are found all throughout the central nervous system. They're all found out throughout the body, and they can create positive effects or they can create those side effects that are out there. All right. So the immune system. If you want to learn about the immune system, you can go to YouTube, go to Ninja Nerd. I really like listening to this gentleman. He helps prepare the students for their medical boards. Here is a nice little review. If you want to, I would encourage you with all the changes that are going on, learn about the innate immune system. He draws it all out. It's the only thing that he really has is kind of this thing in red here, and he draws out, and when this happens and that happens, this is what happens in the innate immune system. Over here is the adaptive. This is probably a good one to review because when that macrophage takes that antigen and it starts to go into T cells and B cells and all these interleukins, right? This is where things can break down. And when you have a breakdown of this part, you start getting kind of that autoimmune side. But he also then talks about the complement system. And this is big because we hear about these complement 3 and these complement 5 inhibitors. And so you got C3, C5 inhibitors that are out there. So again, let me just kind of show you. This is from my thyroid lecture. This is kind of showing now this part here, how this can go awry, right? So we have the adaptive immune system, and we can see a CD4 cell turns into a B cell, a T cell, the plasma cell, and you would get these antibodies that attack the receptors, as we're showing here on the thyroid gland, right? So this is the broken part of the immune system here that's attacking the receptors. And the antibodies, I'm not going to turn this into a thyroid lecture, but the antibodies that are produced are thyroid stimulating, blocking, and peroxidase antibodies that are attacking the thyroid receptors. Well, these same antibodies that are attacking these receptors, creating either the hypothyroid or the hyperthyroid or the euthyroid, they can find the orbit because it's an orbital disease. Unfortunately, the fat muscle skin of the around the eyes have these same receptors, right? That's why it's important to understand receptors. The receptors of the thyroid gland where these antibodies are attacking, those same type of receptors are found in the fat, the orbit, and the muscle, and they attack the eye. And that's what happens in thyroid eye disease. So now why is that important? Because now going to a pharmacology, we have teprotumumab, monoclonal antibody here, which is a biologic agent, Chinese hamster ovary, but it's going after the insulin growth factor 1. That's its mechanism of action. So this is kind of a new mechanism of action, not really a mechanism of delivery change, where it goes and inhibits and calms down the orbit. So this was a medication that was approved in March of 2020 for thyroid eye disease, Tepezza. So if you remember, or thyroid eye disease is an orbital disease. We just talked about how this autoimmune condition is it creates these antibodies blocking, stimulating. They find the receptors up in the orbit and it creates inflammation, low grade chronic inflammation. So here's the fat, here's the muscle, here's the contents of the orbit having these thyroid stimulating receptors, this insulin growth factor 1 receptor. This beta arrestin is really the kicker here. It kind of makes this all one receptor because it connects it. So when that thyroid stimulating antibody comes down, and then we have an insulin growth factor 1 antibody coming down, it activates and creates the inflammation. This being a monoclonal antibody, what it does is it attaches to the insulin growth factor side of the receptor. And because it's all one receptor, because it's beta arrestin, it downregulates it. It doesn't allow that low grade chronic inflammation to occur. So we have this orbital disease. This is all tying everything in together now, right? This is why it's important to understand receptors. It's important to understand the immune system. This one medication here kind of ties it all together is that even though it's going after the insulin growth factor 1 side, it's able to down regulate, not allow the chronic low grade inflammation within the fat, the muscle, the orbit to take over. So this is teprotumumab, which is a newer medication out there, new-ish medication out there for thyroid eye disease. Another one that I want to jump into here is geographic atrophy here. And we see Henley Winkler all over the place. You know, he was on this news channel here, awareness of geographic atrophy, a form of macular degeneration. GA won't wait. Had all these kind of disease awareness type of campaigns. Kind of how I remember Fonzie was this whenever I was growing up, and now here he is out talking about geographic atrophy. But again, it's important out there to understand maybe some genetics. Remember, we're going to talk about two of them right now coming up here shortly. Syfovre, science fovea retina. That's a C3 inhibitor. We're going to talk about Izervay. That's a C5 inhibitor. And I kind of want to talk about these C5s and C3s because that's the complement system. Remember, the complement system and in a sense, what makes a hard drusen, a small drusen, a big fluffy drusen? What makes it fluffy and white around it? Well, probably white blood cells. And those white blood cells are, in a sense, activated from maybe the complement system, right? So that's what kind of makes that soft drusen, soft, white, and fluffy white blood cells complement system. So this is just some genetic testing that I do at the practice. And what I just want to point out here, there's the arms. Here's the complement factor H. Complement factor H, what it does is it slows the immune system down. So if it's got a snip or it's broken, the immune system can't slow down. So that's why I kind of think of macular degeneration as more of an autoimmune disease. It's an autoimmune disease that is attacking the retina. So if it's already got a broken immune system, you can't slow it down. We don't want things to slow it down even more. And that's what high dose zinc can do. And I don't want to get into that tonight. But what I want to point out is you see this C3 SNP. So we got a broken, complement system. Complement systems are broken here. And you can see based upon these arms and complement factor H and C3, we can get whether it's low, medium, or high risk of developing macular degeneration. And again, it goes back to the immune system. Remember, this is the innate, here's the adaptive. And then right here, he has it right here. He talked about, the lectin, the classic, and the alternative. And if you remember, this is what makes that membrane attack complex. It's what kind of plugs in, say it's a bacteria, plugs in like a straw and kind of it can't stop the water from coming in, and that's one of the immune ways for our body to kill those bacteria is through the complement system. And right here, if you look real close, this says C3 and this says C5. So we're talking in this area that the complement factor 3 and complement factor 5 are part of the normal immune system. But in macular degeneration, or especially in geographic atrophy, it could be overactive. And that's why these C3 and C5 inhibitors have come out. So if you just look, complement factor H and macular degeneration, bridging the genetic association and pathobiology. But I just want to point out here, you can see C3A and C5A regulating the sub-RPE deposits, choroidal mononuclear phagocyte recruitment. And then you can see what happens here. If these become broken, what happens in the complement cascade. So this is geographic atrophy. I wish I had the dates on. I have to go back and look, but this was like 2019. This is an autofluorescent of a patient. And when things hyperfluoresce and fundus autofluorescent, that means the RPE. When you do FAF, you're looking at the RPE. It's not the ganglion cell layer. It's not the nerve fiber layer. We're not looking at the inner, or the surface of the retina. We're looking down at the inner retina, or down at the RPE. So when you look at fundus autofluorescent, like, black is dead, right? So this is what has happened to this patient. This was about a 7-year progress, and you can see that this is dead. The RPE is missing, but this is still active right here. And this would be a patient, depending on where the fovea is and their acuity, that they might be a good, C3, C5 inhibitor, a good referral to the retinologist. So this is, obviously these just came out recently, so I couldn't refer them back here in 2018, but here might be a good referral because that fovea could still be intact, and we don't want that to move into that foveal range. So this is a patient of mine that I had in the practice. So Syfovre is Apellis. It was approved in 2023, and it's for the treatment of geographic atrophy. And that's kind of that new mechanism of action that we were talking about, targeting that C3 inhibitor that's out there in our immune system. And if you look over here, this is right from their website. Classic lectin and alternative, right? That's part of the normal immune system, and they're inhibiting complement factor 3, which, as we go forward here, you can see can create inflammation, phagocytosis, cell membrane disruption, which is what we might want to prevent. So it's kind of that balance of the immune system being overactive, but we want to calm it down, but we don't want to stop it because our immune system is important. So a lot of these medications that are out there, do, in a sense, play around with the immune system. Our anti-VEGF medications are like that. So C3 activation, we know that, again, we just talked about it, inflammation, phagocytosis, cell membrane disruption. So if we can inhibit it, we might be able to prevent some of this loss going forward here with this geographic atrophy. So Syfovre is one of them by Apellis. We have Izervay, which is now Astellas. It started off as Iveric, and then is now Astellas, but it's Izervay is still the injection. This was August of 2023 as opposed to February of 2023. So they both came out in the same year. Kind of similar mechanism of action, if you want to say, inhibiting the complement system, but it's inhibiting C5, which is a little bit further down here in the system. So maybe, some of the thought processes, maybe there's less side effects. I think we just kind of have to inject and let time kind of figure out what happens. I think this is nice to have, medications that can help with this geographic atrophy, which we had no help before. So again, this is off of their website, and again, showing you the classic alternative and lectin, which I would encourage you. Again, I have no financial interest in Ninja Nerd other than I like the way he teaches, and you can learn real quick about the immune system, and it will help make sense of what's happening with these complement factor inhibitors that are out there. Now, amptomers and biologics, or amptomers and antibodies, they're all biologics, except that your antibodies, like your teprotumumab, they're less stable, they're more complicated to make. They mess with the immune system, and they're much larger, and that's why they either need to be injected or infused. Where the amptomers that are out there, as it says here, they're more stable, they're easier to synthesize, have less or no immunogenicity, monkeying with the immune system, as I like to say, and they're much smaller in size. So they're both biologics, except one is a little bit more, easy to make, easy, and more stable. Like your anti-VEGFs, your teprotumumabs, your oxervates. Those are biologic agents, and they are, very unstable. You got to be careful with them. So when it comes to, biologics versus small molecular drugs, I just want to talk about the difference here is that, your small molecule drugs are made by mixing and adding chemicals together. That would be kind of what I'm trying to say is like aspirin. It's more organic, inorganic chemistry. Biologics are true in a sense, genetic engineering in a sense. So small molecule drugs can be taken orally, where your larger drugs are usually taken as injections or infusions. So here's a nice little picture here. Here's an aspirin, and they're using Daltons as the size. So you just have to see that you can see it's 180 versus 150,000. And you can see here, this is a monoclonal antibody, IgG, used a lot to treat myasthenia gravis. And you can see that it's kind of twisted and it's loose adhesions. So you don't really like want to be shaking it out there. So their biologics are large, they're complex. Aspirin's kind of like a bike, where these monoclonal antibodies are as complex and maybe as expensive in a sense, like comparison to aspirin to a jet airplane in complexity and in cost, because it truly is genetic engineering. They usually find the DNA sequence. So, for example, let's just take oxyrvate for an example. They found the DNA sequence of human nerve growth factor, and they were able to put it into a biologic process through synthesis, protein synthesis, as we go down through here, using live cells. They use E. coli. And then the proprietary is they're able to spin it and make it and connect it to make it look like human nerve growth factor. Not to bring up a bad wound from 5 years ago, but the COVID vaccine, in a sense, they found out what the DNA sequence was of the COVID virus. In a sense, they cut off everything but the crown, and they replicated the crowns, and that's in a sense one of the vaccines, with in a sense what they were injecting into the body so that your body could have an immune reaction. But as you're going to see here, whenever I talk about Bayview, when you start injecting these things into thousands of people, you start getting a lot of the different side effects. So biologics are not chemicals being mixed. It's DNA, it's a protein, it's being synthesized, RNA, DNA, and then it gets twisted up into the protein or the molecule that you want it to be. So coronal neovascularization is where it's all started with retinopathy of prematurity, diabetic retinopathy, and of course macular degeneration with the anti-VEGF, going all the way back to Macugen, Avastin, Lucentis, Eylea, and Bayview. So if you remember, Bayview came out in October of 2019. It went through the phase 3 studies. It had the 3 months of treatment. So like what happened to that medication? And this is why I always like to say, I got to understand the immune system. You got to understand what's going on in our in the body, in a sense. So what happened was they started inject even after a phase 3, phase 1, phase 2, phase 3, they started injecting this, and as they went back and looked, there was 1,098 complications that they were able to pull up. And they were intraocular inflammations, vasculitis. So intraocular inflammations with vasculitis, artery occlusions, and a few people lost, a vision 15 lines or more. Here's the short of the story. This is a monoclonal antibody. What happened was when they injected it in certain people's eyes, they had an antibody for the antibody. And so it created an immune reaction of these ocular inflammations, retinal vasculitis. So what they said is that, oh, if you want to inject it, just test the person for the antibody. Now, what retinologist is going to do that? But even if they did, even after they injected it the one time, their immune system could create the antibody for the antibody. So you had to keep testing. So that's why that one kind of fizzled away. That's just a great example of, again, these medications are going after the immune system, but the immune system is very particular. It's very persnickety, and everyone is an individual. So that's why after you start injecting these beyond the phase 3, new side effects can occur. So you should always report those. So I'm going to go through these pretty quickly here. I just want to talk about Eylea. You're starting to see, like, just in 2011, wet macular degeneration, diabetic retinopathy, wet AMD, so on and so forth, retinopathy prematurity. Really, they just want to keep adding to the list to help with coverage here. So this is the original Eylea, 2 milligrams, with made by Regeneron, is again the mechanism of action. Again, it goes after that VEGF. Here we talked about that was Beovu, and then what we came out with in 2003 was an 8 milligram. So a little bit more of a high potency type of Eylea that's out there. And so Eylea now has 5 approved indications, and they keep going for more, so that it can more insurance coverage could cover it, right? So it's all about, is it indicated? And then if it is, hopefully the insurance companies will cover it. So Eylea itself is wet macular degeneration, the diabetic edema, the vein occlusions, diabetic retinopathy, and retinopathy of prematurity. That's the 2 milligrams. The 8 milligrams is wet and diabetic macular edema that's out there. But Vabysmo is now approved, and I've been seeing my retinologist use this over the last few years. It's getting better coverage. There's a few foundations out there, at least in my area, helping to cover. But its mechanism of action, again, is an anti-VEGF, but it's going for also the angiopoietin 2 receptor. So, and that right there may reduce inflammation and vascular leakage. So that becomes synergistic. So they're getting a lot. So these patients that are being resistant to some of these other medications, the anti-VEGF portion of that, they're adding now the anti angiopoietin 2 side, and it will help with the inflammation and leakage that's out there. So again, that's what Vabysmo is. You can see here the different VEGF, again, going back to the receptors. There's R1, R2, R3, and this one's going after, in a sense, say the R3 plus the angiopoietin side, kind of getting that synergistic effect. And you can see it's a monoclonal antibody. So it's one of those biologics that's out there. Shifting gear out of retina, moving over to Demodex, collarettes are the pathognomonic sign. You can kind of see here, you kind of have to have the patient look down. You can see the redness and the inflammation from this chronic inflammatory debris, which is truly vomit of the Demodex mite that is building up onto the lashes and creates the inflammatory process. So Tarsus has created a medication called Xdemvy, lotilaner, 0.25%, that inhibits, it's a new mechanism of action that inhibits the GABA chloride channel. And you use it 6 times a day. I'm sorry, you use it twice a day for 6 weeks, right? Now that's what the sales rep will come in and tell you, is that it's 1 drop twice a day for 6 weeks. They have to stay on label when they're sales reps, the MSLs, the medical science liaisons. They usually don't come to the office. You usually see them at the trade shows, or you can meet with them via Zoom. They can talk a little bit more off label, but when your sales rep comes in, they're going to say, yes, you have to use this drop, 1 drop in the affected eye, 1 eye, both eyes, twice a day for 6 weeks. I like to tell the patient until the bottle is empty. Now, I like this one that it's a little bit overfilled, because if they put it in and it does run out, I just say, look, just kind of massage it in, because I usually show the patients what I'm trying to get rid of. My slit lamp camera is usually my best tool for treating this, and I'm able to show them. And so here is a 45-year-old man. He is somewhat symptomatic, and I say that because after I treated him, and he didn't realize how many symptoms he had, but you can see the redness to his eyelids. You can see how it's kind of running down to where this debris, or again, vomit of these Demodex mites is building up at the base of the lashes. And the Demodex mite now has been shown to be living in the meibomian gland. And the recent um, talk that I had with the Tarsus team was how it can help with meibomian gland dysfunction because it gets into the gland and disrupts the oils that are coming out. So you can see here that, this is just 5 weeks after treatment. They look really, really clean. You think that you might want to discontinue at this time, but you really want to go the full length of treatment for the fact that you want to make sure that those eggs, if they hatch, that it doesn't kill the egg, it kills the mite, and it inhibits the GABA chloride channel. You want to get that new mite that was born. So that's why you want to kind of go that 6 weeks or longer so you can get that whole cycle of those eggs being hatched here. So when it first came out, you had to go through more of this kind of process. You had to use like I think it was Blink RX. I use a kind of more local. My rep was in and gave me more local. I think it's Walgreens in the Pittsburgh area that I could use. So I was just kind of going through the timeline here when the RX was written. And then 3 weeks after treatment, again, they look really, really good, but you don't want to stop here. You want to go that full treatment. Again, I tell them to the bottle's empty so that it does kill the mite. It kills the eggs. It doesn't kill the egg, but it lets the egg hatch and then it kills the mite from that hatched, from those eggs that's out there. I'm going to skip this here just for the time's sake. This was the guy that said, hey, my eyes, I didn't realize how bad my eyes felt until you fixed them, doc. But you can see here how much Demodex debris he had, and then we cleaned him up. This is a neurologist that came in. We kind of geeked out a little bit about how this works. He's a patient of mine, a neurologist in town, and I was showing him here all the Demodex and the collarettes and how that's pathognomonic, and then how this inhibits the GABA chloride channel, which humans don't have. And so that's why it's a very safe medication because it's not really going after anything that a human cell or neuron would have. And you can just see how it's all built up. You can see a little even redness and edema to that upper lid. And you can see, just after 3 weeks, this medication works really, really well. But we're not going to stop because we know that there's some eggs around. You can see the redness to the lid margin from what this does. And again, it's been shown to help with meibomian gland dysfunction. All right. So Demodex, it's out there, creates inflammation. It can live in the hair follicle. It's just showing here. It can live in the meibomian gland. It can create mechanical, bacterial, and chemical disruption. We can get disorders of the eyelashes, meibomian gland. So my point is, this is pretty easy to treat. It's not a chronic medication. You prescribe it. You use the specialty pharmacies, and we get some really good results. So I would encourage, anyone out there that has a prescribing license, look for these patients. It's an easy one. It's not like glaucoma chronic treatment. It's not like a cyclosporin or a Xiidra, where it's twice a day, pretty much every day, maybe forever. This here is just a 6-week treatment with some really good results. With that twice a day for 6 weeks is what they say, but I usually just tell them to use it until the bottle is empty. Joe,
Greg,
any comments you want to make?
yeah, interestingly, I've seen it actually work in a week. I happen to have a patient who came back after a week and everything was as good as it probably was going to get. But you're right, you've got to encourage them to keep going. I had a patient, refuse didn't want to finish the bottle. They want to save it in case they needed it again. All right, I mean, you can't save them all.
Yep. So yeah, that's a good comment. I have seen it. I follow my
Mhm.
patients up sometimes. I just take pictures, tell them to come in. Maybe don't charge them. I just want to see what it looks like. Yeah, 7 to 10 days, they start looking pretty good. You inhibit
Greg,
those.
somebody
Yeah.
just asked a question. What's the average cost of Xdemvy? I will tell you the list price is about $2,065, but what you use is a specialty pharmacy that your rep will tell you about. They'll do the prior authorizations, they'll use insurance, and if necessary, they'll go through a grant. It's about a 3-day process. A lot of patients will get it for free. I've seen other patients not able to get a grant, but they get it down to like $850. My best so far, I've had a couple of patients who were covered at $120, which I think is reasonable. And about a week or two ago, I had a patient who was covered at $60. That was just straight insurance.
Yeah.
It's
That's
accessible.
about where I've been. I think the most that someone's might have paid is $100 out of pocket, and a lot of them have been free or kind of something that's reasonable, knowing that
Mhm.
it's going to work quickly. Have you ever needed to retreat? How soon? So I haven't had to retreat yet, because I've only been using it for about a year and a half now. But I do follow up with some tea tree oil, Avenova, or I'm sorry, not Avenova, that's hypochlorous acid, Claridex. Sometimes if I think it's going to come back, the tea tree oil is not as effective as the Xdemvy, but it's a good little maintenance that's out there.
I think the tea tree oil scrubs, they're actually very, I'm told they're very gentle and very soothing. I think it's good for that maybe grade one.
Yeah,
Where
I think
you-
it's an alternative as if you can't get it to be covered, and also good as a maintenance too. So,
Mhm.
and they do make a foam. So Claridex Light. So, all right, let's jump in here to Mibo, perfluorohexyloctane, another one of those new mechanism of action by Bausch and Lomb. Its unique characteristics is that it's 100% drug. It doesn't have a preservative. It doesn't have water. It's a single component. It doesn't sting. It's administered as drops, and it's one drop 4 times a day into both eyes. Again, a very unique characteristic that's out there. And again, we're starting to see that 11 microliter drop size. It's been shown in rabbits to last up to 6 hours in the tear film. It forms a mono layer. It's really targeting that evaporative, mimicking the natural meibum of the tears. Again, preservative free, water free, no inactive ingredients, so it doesn't sting, right? So when you put it in, this is a little bit tricky of a drop because it's so small and it doesn't sting. I've been telling the patients to put it in the refrigerator or just be careful because they'll put it in and they really don't feel it. So be careful with that. Don't maybe go through that whole bottle, which is a small bottle, because it's such a small drop size. What it's doing is targeting that evaporative side. So we have 50% evaporative, 36 of it is kind of mixed. So they say 86% can be, of the dry eyes can be using this medication. What I'm going to do is I'm going to go forward and then come back. I always say I'm going to move this slide and I always forget to do it. But when you have evaporative, it creates desiccation, stress, tissue damage, and inflammation. And so what happens is that when you have evaporative because of the meibum right here breaking down in a sense, what happens is this is what happens when you have tear hyperosmolarity. When it evaporates off, what happens is the tears become very dense. They become what I call salty, right? They become hyperosmolaric. And what it does is the body likes to be in homeostasis. So if this is hyperosmotic, where's it going to get its water from? Well, there's not enough humidity in the air to kind of balance out the tears. So it's going to pull it from the conjunctiva and cornea cells. It's going to pull it from here and it's going to put that stress. And that's what you're seeing here is the stress on the conjunctiva or cornea cells. And if it becomes too stressed, it dies and breaks down and creates staining. So the idea is when you use this perfluorohexyloctane and you have these 6 aerophilic and these 8 lipophilic anchoring into the meibum and in a sense seals it off. So this is what happens when you have evaporation. You get that desiccated stress, tissue damage, inflammation, all kind of spinning out. And that's really because of this right here, that hyperosmotic tear putting that stress on the conjunctiva and the cornea cells. So sealing it off, and creating the right homeostasis brings that balance back. So being that it's kind of 100% molecule, pretty safe medication that's out there. No adverse ocular events, low discontinuation rate, low burning and stinging because there's really no pH, no water in it to create that energy of that, that's out there. So there was no one There was one ocular incident, and that was blurred vision. When you put it in, that was out there. So. All right. So Mibo offers a comfortable experience. Again, I just wanted to target again that trend that's out there with those 11 microliters in size. I want to talk about Vive here real quick. Again, not really a change in mechanism of action, more of a mechanism of delivery. A little bit different from this perfluoral hexyloctane. It's using perfluoral butylpentane, not the same thing, but the mechanism of delivery does allow it to have no pH. It's allowed it to be water free, and it's allowing delivering the cyclosporin to the tissues to allow it to help get there. So cyclosporin is a fat loving molecule. If you can get it to the cornea, if you can get it to the tissue, then it will help with the inflammatory, but it's a fat loving molecule. You're dropping it into water. It's kind of hard to get it to the tissues. So they put it in the perfluoral butylpentane, and it helps it get to the tissues. And again, look at that, a much smaller drop, but look what it does. I think we all know that it took Restasis a lot longer to get that statistically significant improvement of dry eye signs. So changing that mechanism of delivery has helped out. Cequa is another one of those, cyclosporin kind of mechanism of delivery where they're using a nano micellular type of delivery system that's out there. Again, it has the same indication as all the other cyclosporins, going after the inflammatory dry eye cycle that's going on in the eye. But here is that fat loving molecule, cyclosporin. They're wrapping it in this micellular polymer, in a sense, this capsule. So when it gets dropped into the eye, water likes water, so it gets through, and then it kind of releases this. That was the Cequa rendition of trying to help get the cyclosporin to the lacrimal gland, to the conjunctival tissue, to the cornea, to help with that inflammatory type of dry eye. And they did some head to head. There's a phase 4 study. So phase 4 studies are after it's approved, and a lot of the head to head studies that are out there. And you could see that, that Cequa did help out with the cornea fluorescein staining and the symptoms that are out there. So, if you're having failures with your Restasis, consider Cequa, consider Vive, that's out there for your patients. And that's why you'll see maybe the nano dropper. The nano dropper is a device that is compatible for most bottles. I'll go through this here quickly, that you can attach it. It's got this bullseye. So you take off the lid and you screw this on, and it shrinks the drop down to a very small size. So again, here's the bottle that you would get. You put this on, you screw this on, you pop this cap off. It makes a nice little bullseye, but it shrinks that drop down. And they've done studies where it doesn't affect the efficacy of the medication. And you can see it's compatible with about 90% of the bottles. I do want to talk about, as we wrap up here, I won't get to the glaucoma medications or Ella here because we're getting right to that time. But I want to talk about presbyopia to wrap up here. It's not going away. It's a big market, a $3 billion market. The population is aging, and our first medication that came out was Vuity, right? This was Allergan and then AbbVie. This was October of 2021. It was QID dosing, then BID dosing. But what they did here is they changed the pH, right? Regular pilocarpine was 4% back in the day when I was treating glaucoma at PCO before. We were using 1, 2, and 6% to treat our glaucoma patients. It would burn, right? It was a burning drop, pH of 4. The eye is 7.2. So what they did here, to kind of recap, is they did this fast pH, spelled with a pH, fast technology, to help raise it so that it didn't sting, but it also helped with the onset of the mechanism of action. Now, another pilocarpine, now this was percentage was 1.25. Another pilocarpine that came out was was 0.4%, and that is Close, and that is a new medication that was recently approved, and it's low dose pilocarpine. The last medication that I'll talk about here, and then we'll move into some of the housekeeping, is Lens 1.0 or aceclidine, 1.44%. This is kind of cool. You go to a meeting. I was at Vision Expo East, Vision Expo West, or at Seco, and they have a big presence there in their disease awareness, and it's a pupil. It's not pupil sparing. It's pupil targeting a ciliary body sparing molecule. It's going after the pupil and it's getting it to 2 millimeters in size. Aceclidine is the only pupil effective miotic, and this is really the key here. When I was talking to the medical science liaison, it's targeting the iris sphincter versus the ciliary muscle at a 20-to-1 ratio. So it's really going after the iris sphincter, leaving that ciliary body alone to a 20-to-1 ratio. So when I asked about pilocarpine, it was a 2-to-1 ratio. So you get the iris pilocarpine, you get the iris to constrict to get that depth of focus, but you also get ciliary body and that myopic shift. So that's why this is going to be pretty exciting, is you're going to get that depth of focus with this medication. And they did a clarity study where it showed rapid onset, 71% with a greater than 3-line improvement. You get the 90% improved near vision, 75% continued to use after the study, and 81% said they would use it 4 to 7 days a week. The biggest side effect, again, it is a pilocarpine-ish cousin type of medication, a miotic, and it does create some headache. There was some stinging and some dimness from that pupil. That has a PDUFA date of August 8th. So keep that in mind. That's just right around the bend here. So with that said, I do want to stay on time tonight because we do have the product theater. I didn't get through this, so maybe I'll just have to come back and do another rendition here. But I do want to do some housekeeping and remind people what's going on. And let me just share this. Joe has left to open up the product theater. So now let me share my screen again. And let's see if there's any other questions. Thank you. Costa Mybo. Again, just use your sales reps that's out there. They'll help you walk through it. There's a prior authorization. It's a specialty pharmacy that's out there. I'm just looking at the questions right now. And I'm getting some thank yous that roll in here. So you're welcome. So in order to stay on time and finish up here in 4 minutes, thank you for attending tonight's education. This is our national webinar series. This was Pharmaceutical Advances. What's new in patient care? This was a synchronous course. Thanks for trusting Optometric Education with your education.